Section 1, Throat and Breathing Blocks, specifically esophageal atresia and TEF. Let's start right at the top of the airway and see what happens when the swallowing tube doesn't connect to the stomach the way it should. Now, you might already know this, but when we see an anatomical block in the throat, it's rarely just an isolated incident. These developmental hiccups actually tend to come bundled with a whole package of other anomalies. We use the acronym VACTERL to remember them all. It stands for vertebral, anal, cardiac, tracheoesophageal, renal, and limb anomalies. In simple terms, if you find an issue in the throat, you have to actively hunt for these other potential defects just to make absolutely sure you aren't missing a hidden crisis elsewhere. And this table brilliantly illustrates the different layouts of this exact defect categorized into gross types A through E. Take a really close look at that highlighted row right there, type C. This is your classic exam trap and honestly the most common presentation in real life. So in type C, the upper swallowing tube ends in a blind pouch, meaning it literally goes nowhere. Meanwhile, the lower part of the tube inappropriately connects the stomach straight into the windpipe, creating a fistula. Because of that blind upper pouch, if you try to pass a feeding tube down the baby's throat, it's just going to hit a brick wall and coil right back up on itself. Let's anchor this with the classic presentation. Imagine a newborn trying to feed. If the milk can't reach the stomach, it just spills over into the airway, causing choking, coughing, and cyanosis. That bluish discoloration from a lack of oxygen. You'll also notice excessive salivation, because even their own spit has nowhere to go. And here's a really fascinating backward-looking clue. During pregnancy, a fetus normally swallows amniotic fluid, right? Well, if they have esophageal atresia, they can't swallow it. That leads to a massive buildup of excess fluid around the baby in the womb, a condition called polyhydramnios. Moving on to Section 2, hernias of the diaphragm, focusing on congenital diaphragmatic hernia. We are moving down the body now to the muscular barrier right where the chest and abdomen meet. This brings us to a critical mechanical failure. What actually happens when this barrier has a literal hole in it? Well, usually on the left side, which is known as a Bochdalek hernia, the abdominal organs, like the intestines, simply slide right up into the chest cavity. This completely squishes the developing lungs, leading to severe respiratory distress right at birth. Physically, you're going to see a scaphoid or sunken abdomen because the organs that should be making that belly nice and round are currently sitting up in the chest. If you listen with a stethoscope, you'll actually hear bowel sounds where you should absolutely be hearing breath sounds. Crazy, right? So the absolutely crucial point here is how you react in those first frantic minutes. Look at step 1. Do not use bag mask ventilation. Think about it. If you pump air into this baby's mouth, it goes into their stomach and intestines. And where are those intestines? They're in the chest. You will literally inflate the bowels and crush whatever working lung tissue that poor baby has left. Instead, you have to intubate immediately. Drop a tube down to decompress the stomach and ventilate with very gentle pressure. And finally, look at step 5 because this is a massive clinical trap. You do not rush this baby to surgery. No way. You must stabilize their blood pressure and manage their pulmonary hypertension first. Physiology always comes before anatomy. Section 3, abdominal wall defects, gastroschisis versus omphalocele. Continuing our journey, we encounter two very different structural defects right on the surface of the belly button area. It is absolutely vital to clearly contrast gastroschisis and omphalocele because, yeah, they look kind of similar, but they have totally different implications. The ultimate diagnostic turning point here is the membrane. Notice the image on the left for gastroschisis. See the exposed bowel with absolutely no covering sac? The bowels are just out in the open, angry and inflamed from floating around in amniotic fluid. Now look at omphalocele on the right. That's a midline defect straight through the belly button where the bowel and sometimes even the liver are neatly sealed inside a translucent membrane. Why does this distinction matter so much? Because an omphalocele is heavily associated with severe cardiac and chromosomal abnormalities, like Beckwith-Wiedemann syndrome, whereas gastroschisis usually is not. All right, Section 4, the double bubble obstruction, or duodenal atresia. Let's move to the junction of the upper stomach and the intestines and see how this builds. So whenever we talk about duodenal atresia, which is just a failure of the duodenal tube to open up properly during embryonic development, there is one specific number you've got to keep in mind: 21. There is an incredibly strong genetic association between duodenal atresia and trisomy 21, commonly known as Down syndrome. It is a huge watch-out for any medical professional. To put it simply, if a newborn baby has bilious green-colored vomiting, you must assume they have a complete intestinal blockage until proven otherwise. See, green bile enters the digestive tract just past the stomach, so if the vomit is green, that means the traffic jam is happening after the bile duct. The definitive proof of this is the famous double bubble sign on an X-ray. Bubble 1 is the fluid and air-filled dilated stomach. Bubble 2 is the dilated upper duodenum right before the blockade. You're going to see little to absolutely no gas beyond that point, simply because nothing can get through. Section 5. Lower bowel blockages, specifically Hirschsprung disease. For our final anatomical stop, we're looking at the lower colon and rectum, where an invisible defect causes a major physical blockage. The entire key to understanding Hirschsprung disease is actually right here in this one single word, aganglionic. Normally, your bowel has this super complex network of nerve cells, ganglion cells, that act kind of like traffic cops, telling the bowel muscles to relax and let waste pass through. Well, in Hirschsprung disease, these nerve cells are congenitally absent in the distal bowel. Without those nerves, the affected section of the colon stays permanently, tightly clamped shut. It literally acts like a concrete wall, trapping all the gas and stool in the normal healthy bowel right above it. Look at how these symptoms stack up sequentially on this timeline here. At birth, everything actually seems fine. But as we cross that 48-hour mark, there's a delayed passage of meconium, the baby's first stool. The abdomen starts to dangerously distend, and bilious vomiting begins because that backup has literally reached all the way up the GI tract. Then, at point 3, a doctor performs a digital rectal exam. By mechanically forcing that tight aganglionic muscle to open with just a finger, all that trapped, highly pressurized stool above it violently shoots out. This is the classic explosive squirt sign, and it brings a really dramatic, albeit temporary, relief. Breaking down the testing protocol for this is so crucial. Your best initial test is a contrast enema. It beautifully outlines that tight, narrow aganglionic zone, which contrasts really sharply with the massive, dilated, normal bowel sitting above it. But to officially prove it, you need the gold standard, a rectal suction biopsy. You have to literally look under a microscope and confirm those nerve cells are missing. The ultimate danger you've got to watch out for while diagnosing this is enterocolitis. It's a sudden, life-threatening infection presenting with explosive diarrhea and sepsis. Once the baby is stabilized, the definitive fix is surgical, a pull-through procedure, where that defective, nerveless bowel is removed entirely. And finally, Section 6, Rapid Revision Summary. Let's tie it all together and lock in this heavy influx of medical data. Now, what's really brilliant about this slide is how it perfectly maps out every single condition into a simple, easy-to-read cheat sheet. Delayed meconium and explosive stool, that's Hirschsprung. Confirm it with a biopsy. Choking with feeds in a coiled tube, that's TEF, fix it with an anastomosis. Scaphoid abdomen with respiratory distress, CDH, and remember, stabilize first, absolutely no bag mask. Exposed bowel, gastroschisis if there's no membrane, omphalocele if there is one. And finally, bilious vomiting with a double bubble, duodenal atresia. Everything we've discussed today is neatly contained right here, side by side, making it virtually impossible to confuse these critical emergencies.
Section 1. The neonatal obstruction emergency.
Before we even get into specific diseases, we really need to set the scene. When a newborn baby's intestine is blocked, the stakes literally could not be higher. There are very specific clues that doctors look for to realize a baby is in immediate danger, and here is the ultimate exam trap and a real-life clinical rule. If a newborn throws up green, bile-stained fluid, which we call bilious vomiting, it is 100% an intestinal obstruction and a surgical emergency until proven otherwise. Bile is just green digestive fluid, right? So if it's coming up, it means there's a total roadblock further down in the plumbing.
Our second major clue is meconium. Now, meconium is simply a newborn baby's very first poop. It's naturally thick, dark, and sticky. A baby failing to pass this meconium within their first day or two is an absolute anchor point for diagnosing many of the conditions we're about to investigate. Basically, if the plumbing is blocked, the meconium can't get out. Section 2. Jejunal-ileal atresia and meconium ileus. That brings us to our second case file. We're going to look at two distinct but critical blockages that happen right in the middle of the small intestine. First up is jejunal-ileal atresia. The word atresia basically just means a dead end. This is a congenital interruption of the intestine, and it's usually caused by a vascular accident, meaning a brief loss of blood supply while the baby is still in the womb. So what are the warning signs? Well, the baby fails to pass meconium. Their belly becomes swollen or distended, and they have that dangerous bilious vomiting we talked about. Sometimes even before birth, there might be extra fluid around the baby, known as polyhydramnios. On an X-ray, you'll see multiple air fluid levels and dilated, swollen loops of bowel.
To treat this, the medical team immediately starts resuscitation. They use a nasogastric tube to decompress the stomach, pump in IV fluids and antibiotics, and ultimately, this is always going to require surgical repair to reconnect that intestine. And this brilliantly illustrates the difference between our first two conditions. Let's compare jejuno-ileal atresia with meconium ileus. While atresia is a physical dead end from a vascular accident, meconium ileus is a blockage caused by the meconium itself being just way too thick and sticky. Why is it so sticky? Because it's strongly associated with cystic fibrosis. This ultra-thick meconium blocks the end of the small intestine. And because it's a dense, sticky mass, an X-ray doesn't show those clear fluid levels. Instead, it shows a soap bubble or ground glass appearance down in the lower right side of the belly. Here's the wild part. Unlike atresia, which always needs surgery, meconium ileus can sometimes be flushed out without surgery, just using a special water-soluble contrast enema. But meconium ileus isn't always that simple. If that thick meconium just sits there, things can go wrong incredibly rapidly. Complications include a microcolon, which is where the unused lower colon literally shrinks down. Worse, the heavy, blocked bowel can twist on itself, and that's called a volvulus. The pressure can even cause a complete secondary blockage, an atresia. It can even pop, creating a perforation or a hole in the bowel, which leaks meconium out into the belly, causing massive, dangerous inflammation called meconium peritonitis.
Section 3. Malrotation and midgut volvulus.
Speaking of twisting bowels, I really have to warn you, this specific condition moves incredibly fast, and it's highly, highly dangerous. Let's look at the core pathology here. While a baby is developing as an embryo, their intestines actually grow outside the belly and then rotate back inside, fixing themselves to the abdominal wall. Malrotation means this rotation and fixation happened abnormally. The result? The intestines are left dangling on a very narrow base of tissue called the mesentery. Because that attachment base is so narrow, the entire intestine is completely vulnerable to twisting around itself, kind of like a tangled garden hose. Let's move to the timeline and see how this builds into a total catastrophe. It starts with that classic alarm bell, bilous vomiting. Soon, the baby's abdomen distends and swells. Because the bowel is twisting, it physically chokes off its own blood supply. This is bowel ischemia. Without blood, the tissue literally starts to die, leading to peritonitis, which is severe abdominal inflammation. Finally, the baby goes into shock. This whole terrifying progression can happen in just a matter of hours.
So how on earth do we catch it before shock sets in? Well, if the patient is stable enough, an upper GI contrast study will show the intestine is in the wrong position. But the real smoking gun is on an ultrasound. Doctors are looking for the whirlpool sign, which literally shows the blood vessels swirling like a tornado right where the bowel has twisted. The treatment for this? An immediate, urgent surgery, called the LAD procedure, to untwist the bowel and broaden that base so it can't ever twist again. Remember that golden rule. Bilious vomiting means malrotation until proven otherwise.
Section 4. Necrotizing enterocolitis, or NEC.
Now let's shift our focus to a totally different kind of threat. The typical patient for NEC is a premature, low birth weight neonate whose gut just isn't fully developed yet. The clinical features usually start in the belly. The abdomen swells up, they can't tolerate their milk feeds, and they might have bilious vomiting. But NEC doesn't just stay in the belly. It goes systemic. The baby will start having bloody stools, severe lethargy, temperature instability, meaning they just can't stay warm, and apnea, which are terrifying pauses in their breathing. The infection and inflammation are affecting their entire tiny body.
When doctors suspect NEC, they immediately order an X-ray looking for this exact medical term, pneumatosis intestinalis. Let's break that jargon down. It simply means there are gas bubbles trapped directly inside the actual tissue wall of the intestine. Bacteria have invaded the bowel wall and are producing gas right there inside the tissue. Seeing this is the ultimate red flag for NEC. You might also spot gas in the blood vessels going to the liver, or free air in the belly if the bowel has already popped.
So the crucial point here is how we stop this infection from completely destroying the bowel. The initial management is a strict, highly aggressive medical protocol. Step 1, you stop all milk feeds immediately to give the gut a rest. Step 2, place a tube in the nose to decompress the stomach. Steps 3 and 4, pump in IV fluids and hit the infection hard with broad-spectrum antibiotics. Now, because the baby can't eat, Step 5 is providing all their nutrition intravenously. And finally, Step 6, the doctors will do serial exams and X-rays, checking the baby constantly to make absolutely sure the condition isn't worsening.
Most times, that strict medical rest works. But if it doesn't, the medical team is forced to abandon it and rush the premature baby to surgery.
The absolute triggers for surgery are a perforation, which is a physical hole rotting straight through the intestine, pneumoperitoneum, which is free air in the belly proving that a hole exists, or simply if the baby's clinical condition just keeps rapidly deteriorating despite all those maximum medical treatments we just discussed.
Section 5. Meconium and colon syndromes. Moving further down the digestive tract, let's look at two lower bowel obstructions that can often be fixed without any surgery at all. Let's compare these two side by side: meconium plug syndrome and small left colon syndrome. Both present really similarly. The baby fails to pass meconium, gets a swollen belly, and vomits. Now, meconium plug is exactly what it sounds like, a really thick plug of meconium causing a functional traffic jam. Small left colon syndrome is also a functional block, but it features a physically narrowed left colon. And here is a massive clue for you. It is strongly associated with maternal diabetes. But honestly, the most incredible fact about both of these conditions is the treatment. A simple contrast enema is used to X-ray and diagnose the problem, and the fluid from the enema itself often flushes out the plug or dilates the colon, curing the baby right then and there. It's amazing.
Because of how easily these can be confused with surgical emergencies, you really have to remember this exam trap. I'm going to read it verbatim as a key takeaway for you. Neonate with failure to pass meconium, but no clear mechanical obstruction, meaning no twisted bowels or dead ends on those early scans, consider meconium plug syndrome or small left colon syndrome.
Section 6. Rapid Revision Summary Table.
We've investigated a lot of complex medical evidence today. Let's bring it all together on our ultimate detective's evidence board. Now, what's really interesting about this summary is how beautifully it organizes our 5 major suspects. Let's walk through it row by row. Jejinoileal atresia. You're looking for a basic neonatal obstruction with dilated bowel loops, and it requires surgical repair. Meconium ileus, the massive clue is cystic fibrosis, giving that soap bubble X-ray appearance, and it's often fixed with a contrast enema. Malrotation in volvulus, the undeniable clue is bilious vomiting with a whirlpool sign on ultrasound, demanding an urgent lab procedure. NEC. The victim is almost always a premature neonate. The key finding is gas in the bowel wall, pneumatosis intestinalis, requiring strict medical rest and sometimes surgery. Finally, meconium plug and small left colon. The clue is simply a failure to pass meconium, and that contrast enema is the magical cure.
I want to wrap up this explainer by testing.
Section 1. Hypertrophic pyloric stenosis, the case of the hungry infant. To crack this first case, timing is everything. It's a huge clue. Imagine a baby who drinks a full feed, suddenly, forcefully vomits it all up clear across the room, and then immediately starts crying because they're starving again. But look closely at the timeline here. This condition doesn't usually happen at birth. You won't see this in a day-old newborn. The muscle at the base of the stomach, the pylorus, it actually thickens over time. So that classic presentation of progressive projectile vomiting, it happens very specifically in the 2 to 8 week old window, and mostly in infant voice. Now, watch out for this classic exam trop. Not all vomit is created equal. In pyloric stenosis, the vomit is non-bilious. It basically looks exactly like the milk the baby just drank. Why? Well, because the blockage is proximal, meaning it's before the point where green bile enters the digestive tract at the ampulla of Vater. The food literally never makes it out of the stomach. This leaves the kid constantly hungry, and if you feel their belly, you can actually feel that overgrown stomach muscle. It feels just like a firm, olive-shaped mass right there in the upper right quadrant.
So, because the baby is constantly throwing up stomach acid, they run into a massive biochemical roadblock. You'll probably hear this terrifying sounding medical term, hypochloremic, hypokalemic, metabolic alkalosis. I know, it's a total mouthful. But all it really means is the baby is losing hydrochloric acid and fluids from throwing up. This totally drains their blood of chloride and potassium, leaving them dangerously alkaline and severely dehydrated.
To back up our detective work, we use an ultrasound to measure that bottleneck. It's super simple. If the hypertrophic muscle thickness is 3 millimeters or more, and the pyloric channel length is stretched to 15 millimeters or more, boom, you've got your definitive diagnosis.
Okay, so once we know what it is, how do we fix it? Here's another major trap. Your instinct might be to rush this baby straight to the OR. Absolutely do not do that. Step 1 is always to correct the dehydration and those dangerous electrolyte imbalances with IV fluids first. Only when the baby is totally biochemically stable do you move on to step 2. That's the definitive surgery, the Ramstead pyloromyotomy, where the surgeon simply snips that tight muscle to open everything back up.
Section 2. Unpacking intussusception, or telescoping bowels. We're moving a little further down the digestive tracts now to look at a pretty bizarre physical phenomenon. Intussusception is when one segment of the bowel literally folds or telescopes right inside an adjacent segment. Usually, it's the ileum telescoping into the colon. And just like our last case, age is a massive clue. Our timeline shifts a bit older here. These babies have grown into toddlers. Intussusception most commonly strikes between 6 months and 3 years of age. If you see this outside that window, your detective radar should absolutely be going off that there's some underlying anatomical cause.
This is your ultimate cheat sheet for the clinic. Let's map the classic symptoms directly to what you'll physically see. The classic triad is intermittent colicky, abdominal pain, vomiting, and current jelly stool. Although, honestly, that jelly stool is a pretty late sign of bowel ischemia. Physically, you'll see the kid drawing their legs up in waves of pain. If you feel the abdomen, the telescoped bowel feels like a sausage-shaped mass. And since the bowel has physically moved, it leaves this empty space in the right lower quadrant, a major clue famously called the dance sign. Oh, and on ultrasound, that telescoped bowel looks exactly like a target or a donut. So the real turning point in managing intussusception is all about the child's stability. If the kid is stable with no signs of peritonitis, meaning the bowel hasn't ruptured, a pneumatic air enema is basically magic. They literally pump air up the colon and the pressure just pops the telescoped bowel right back out. It diagnoses and fixes it, all at once. But if there's any sign of perforation, shock, or infection, the air enema is totally unsafe. That means an immediate trip to surgery.
Section 3. The Meckel diverticulum mystery. Remember earlier when I said if a kid gets intussusception outside that 6-month to 3-year window, there might be a physical anchor pulling the bowel inside itself. Well, that anchor is often a pathological lead point, like a Meckel diverticulum. To remember this weird little leftover piece of human embryology, you just need the rule of 2s. First off, it affects exactly 2% of the general population.
Let's run through the rest of those 2s, because they basically give you its exact address and job description. It's located within 2 feet of the ileocecal valve. It's about 2 inches long. It typically shows up before 2 years of age. And most importantly, it can contain 2 types of ectopic or out-of-place tissue, gastric and pancreatic. By far the most common is ectopic gastric mucosa, which, means there's literally stomach tissue growing inside the lower intestine. And here's the kicker. That out-of-place stomach tissue secretes acid, but the lower intestine is definitely not built to handle stomach acid, so it forms these painful ulcers that bleed. Because of that, the classic presentation you absolutely cannot miss is painless lower gastrointestinal bleeding in a child. Seriously, if you see a kid with a lot of painless blood in their diaper or stool, it is Meckel diverticulum until proven otherwise. To catch the culprit, a regular X-ray just isn't going to cut it. Step 1 is a super specific investigation called the technetium 99M per technetium scan. This nuclear scan essentially lights up that ectopic gastric mucosa so you can see exactly where the rogue stomach tissue is hiding. Step 2, if it's causing symptoms like bleeding or triggering intussusception, it's surgical resection to take that pouch completely out. Section 4. Paediatric appendicitis. Okay, moving further down, we had a condition you've probably heard about a million times, appendicitis. But we're looking at it with a specific pediatric twist. There is a huge structural difference between adults and kids here. Adults have a fully developed omentum, which is basically a fatty layer inside the belly that acts like a biological fireman, rushing in to wrap around an infected appendix and wall off the infection. Kids, their omentum is underdeveloped. Plus, they have a way harder time telling you exactly where it hurts. Because of these vague symptoms and the lack of that protective fireman, kids often present late and are at a way higher risk for early catastrophic perforation and full-blown peritonitis. The classic flow of symptoms starts with periumbilical pain, so pain around the belly button that stubbornly migrates down to the right iliac fossa or the lower right side. Throw in some anorexia, meaning they refuse to eat, plus nausea and a fever. Now, while this is mostly a clinical diagnosis, watch out for the imaging trap. In adults, we often default to a CT scan, but in kids, ultrasound is your absolute best first-line imaging. We always want to avoid zapping growing kids with unnecessary radiation if we can help it. Section 5. Swallowed objects and chemicals. All right, stepping away from anatomical quirks for a minute, we really need to look at what happens when toddlers swallow things they definitely shouldn't. There's a massive safety trap you have to know here.
If a kid swallows a shiny flat-button battery and it gets lodged in the esophagus, it conducts an electrical current right against the wet tissue. This causes rapid, severe necrosis and can literally burn a hole into the trachea or major blood vessels in just a matter of hours. It requires immediate emergency endoscopic removal, no waiting around. On the flip side, if a child swallows a caustic liquid, like household bleach or drain acid, do not make them throw up. If you induce vomiting, that chemical just burns all that delicate esophageal tissue a second time on the way back up. Don't try to neutralize it either. You just secure the airway, keep them fasting, and use an endoscopy to check out the damage and monitor for long-term scar tissue.
Section 6. The Rapid Revision Table. We have covered a ton of ground today, from the stomach down to the bowel, and even some external hazards. As promised, let's connect every single classic clue to its key investigation and definitive treatment so absolutely nothing gets missed. Seriously, take a screenshot of this master table. Look at the flow: pyloric stenosis, projectile non-bilious vomiting, diagnosed by ultrasound, fixed by pyloromyotomy, after sorting out the electrolytes, of course. Intussusception gives you colicky pain and a target sign, treated beautifully with an air enema if they're stable. Meckel diverticulum is that painless GI bleed tracked down by a TC99M scan. Appendicitis has that classic migratory pain, checked first via ultrasound. And caustic congestions, endoscopy, and absolutely no vomiting. It is all right here, perfectly organized. So the final provocative thought I'll leave you with is this.
Blocked ducts, biliary atresia.
Okay, so biliary atresia is a true surgical emergency in neonates. And to really get it, we've got to look at the core pathology. The textbook calls it progressive fibro-obliteration, which, yeah, is quite a mouthful. But let's translate that into simple words. Imagine the tiny tubes, the bile ducts, that carry bile from a baby's liver down to their intestines. Fibro-obliteration literally just means progressive scarring is completely blocking those tubes from the outside. And because the pipes are blocked, the bile has nowhere to go, so it backs up into the liver and causes severe damage. It's a plumbing crisis, plain and simple.
So what does this plumbing crisis actually look like from the outside? Well, these are the classic signs a parent or doctor is going to see. You've got a baby with persistent jaundice, that yellowing of the skin that hangs around beyond the normal 2-week mark. Their urine is dark, but honestly the most massive red flag. Pale or clay-colored stools. Medically, we call this a colic stool. You'll also feel an enlarged liver, and lab tests will show mainly conjugated hyperbilirubinemia. The best first step to check for this? Grab an ultrasound, and you're specifically looking for something called a triangular cord sign and a gallbladder that's either super small or just totally absent.
Now, let's move to the timeline and see how this builds, because time is tissue here, guys. A baby is born, and by 2 weeks, that persistent jaundice is flagged. This is a massive surgical emergency when it comes to timing, because we desperately need to get to the third step, the Kasai portoenterostomy. This is an early surgical intervention where surgeons basically bypass those scarred-up ducts and attach a loop of intestine directly to the liver to let the bile drain out. The earlier you do this, like before severe liver scarring sets in, the much better the outcome. And if the Kasai fails later in life, well, a liver transplant becomes the next necessary step.
And that brings us to a really crucial golden rule. You see this as an exam trap for medical students all the time, but it's a vital rule for everyone to remember. Pale colic stool in a newborn means blocked ducts until proven otherwise, period. Now, sometimes you'll see doctors use a HIDA scan to try and see if bile is moving, but a HIDA scan isn't quite enough to definitively prove biliary atresia. To get that definitive proof, surgeons literally have to look directly at the ducts using a dye test during surgery and intraoperative cholangiography.
Moving right along. Section 2. Dilated ducts, choledochal cysts.
Now we're moving from pipes that are blocked and scarred to pipes that are stretched out and ballooning. And what's really interesting about this slide, the Todani classification, is how beautifully structured it is. It maps out exactly where the ballooning is happening. Let's systematically break this down. Type I is a ballooning of the outside extrahepatic bile duct. Type 2 is like a little pouch or diverticulum just hanging off that outside duct. Type 3 happens right where the duct meets the inside of the intestine. Type 4 involves multiple cysts, and those can be inside and outside the liver. And finally, type 5 is cysts exclusively inside the liver. The absolute best way to map all this crazy anatomy out in a patient is using an MRCP scan.
But we need to clear up a very common misconception here. You don't see all these types equally in the real world. Type I makes up the vast majority of these cases. It's your classic extrahepatic ballooning. But it is definitely worth knowing the special names for the rare ones. Type 3 is specifically called a Cholidaco cell, and Type 5 goes by Caroli disease. Okay, so how do we fix a ballooning duct? The steps are strict. Step 1.
Complete surgical excision. You absolutely have to remove the cyst entirely. Step 2, reconstruct the plumbing using a Roux-en-Y hepatojejunostomy. The huge takeaway here, and please don't miss this, is that you cannot just pop a drain into the cyst and call it a day. Simple drainage is a massive mistake. Why? Because leaving that abnormal cyst tissue behind carries a very, very high risk of it eventually turning into a deadly cancer called cholangiocarcinoma. Bottom line, it all has to come out.
All right, Section 3, blood backups, pediatric portal hypertension.
So we are shifting from bioplumbing to blood plumbing now, and this brilliantly illustrates one of the most fascinating paradoxes in pediatric surgery, the EHPVO paradox. EHPVO stands for extrahepatic portal vein obstruction. Basically, the main vein bringing blood into the liver gets blocked. A lot of times this is from an umbilical catheter used when they were a sick newborn, or maybe from severe dehydration. On one side, you have terrifying symptoms, right? An enlarged spleen and the child literally vomiting blood from swollen veins called varices. But on the other side, their liver function lab tests are relatively normal. How is that possible? Well, because the blockage is outside the liver. The liver itself is totally fine. It's just not getting the blood flow it needs.
So, if a child comes in actively bleeding from these swollen veins, we follow a very logical progression to save them. First up, resuscitation. We're talking fluids and blood products. Second, vasoactive medications to specifically lower the blood pressure in those swollen veins. Third, we go in with an endoscope and actually tie off the bleeding veins using tiny rubber bands. That's endoscopic variceal ligation. But the definitive fix? That's step 4, the mesorhizial bypass. This is an absolutely incredible surgery that literally builds a new bridge to route the blood completely around the blockage and directly back into the liver, restoring normal physiologic blood flow. It's a total game changer.
Section 4, childhood tumors, hepatoblastola.
Hepatoblastoma is the most common primary malignant liver tumor we find in young children. Usually, a parent will just notice an unexpected abdominal mass or swelling. I really want to anchor you immediately with this number on the screen, 5. Hepatoblastoma overwhelmingly targets very young children, specifically those under 5 years old. If you've got an older child or a teenager with a liver tumor, you are usually thinking of something else entirely, like hepatocellular carcinoma. But under 5, hepatoblastoma is for sure your prime suspect.
So how do we confidently identify it? Well, beyond the patient's age and the physical mass itself, the absolute biggest marker is a markedly elevated blood protein called alpha-fetoprotein, or AFP. If you see a young kid with a liver mass and sky-high AFP numbers, it points directly to hepatoblastoma. There are also some really interesting risk factors here, like a history of prematurity or low birth weight, along with specific genetic conditions like Beckwith-Wiedemann syndrome, familial adenomatous polyposis, or hemihyperplasia.
Treating this requires a solid, dual approach. The ultimate goal is to shrink the tumor down with chemotherapy, followed by a complete surgical removal of the mass. This is exactly why an ultrasound and especially CT or MRI scans are so vital early on. The surgical team needs a perfect 3D map to see exactly where the tumor is sitting, whether it's spread, and if it can actually be safely cut out while still leaving enough healthy liver behind to function normally.
Section 5, the final fix, pediatric liver transplantation.
Look, sometimes, despite the absolute best early interventions, the liver simply cannot be saved. So the crucial point is, why would a child need a completely new liver? There are a few major reasons: sudden acute liver failure, metabolic liver diseases, end-stage chronic disease, and unresectable liver tumors. But the number one reason on that list? Biliary atresia with a failed Kasai surgery. That exact condition we talked about right at the start of this explainer is actually one of the absolute most common reasons a child ends up needing this life-saving transplant procedure.
Getting a liver, whether that's from a living donor or a deceased donor, is really just the beginning of a whole new journey. We usually divide the post-transplant complications into early and late risks. Early on, the surgical team is watching like hawks for primary graft dysfunction, vascular blood clots, bile duct leaks, or acute immune rejection, where the body immediately attacks the new organ. Down the line, the late risks shift toward chronic immune rejection, recurrence of the original disease, or issues stemming from the fact that the child will need to take immune-suppressing drugs, like tacrolimus, literally for the rest of their life.
Section 6, Rapid Revision, Key Takeaways.
We have covered a tremendous amount of ground today. Let's bring everything together in this master summary table to ensure absolutely no points are missed. Let's walk through this logic row by row. If you see persistent jaundice and pale stool, think biliary atresia. The treatment is the Kasai portoenterostomy. If you see a ballooning, dilated duct, Think choletocal cyst. Remember, Tadani type 1 is most common, and the treatment is total excision, never just drainage. If you see a child with an enlarged spleen and bleeding varices, but completely normal liver function, think extrahepatic portal hypertension. Fix it with a mesorex bypass. If a kid under 5 has a liver mass and huge AFP numbers, it's a hepatoblastoma. Hit it with chemo and resection. And finally, if that early Kasai procedure fails and end-stage liver disease sets in, liver transplantation is the ultimate answer.
We've just translated anorectal malformations. Let's look at the anatomy and reconstructive principles.
So in really simple terms, babies with this defect are born with an abnormal or even entirely missing anal opening. And as you can imagine, this is a massive problem. It leads to trapped meconium, which is the baby's first stool, causing severe abdominal distension. Sometimes you won't see any meconium passing at all, or you might spot it coming from an abnormal opening, a fistula, somewhere else. And actually, the specific location of that fistula, that fundamentally dictates exactly how we manage the patient.
Now here is a classic exam trap, so pay close attention. When you see a newborn with an absent anus, you can't just stop looking there. You've got to be a clinical detective and search for the Factor L-associated anomalies. It's a handy acronym: vertebral, anal, cardiac, tracheoesophageal, renal, and limb defects. You also have to rigorously assess the genitourinary system plus the spine and sacrum, because the patient's long-term functional outcome heavily depends on their sacrum and sphincter complex.
If the baby needs surgery, we usually go with a definitive reconstructive procedure called a PSARP, or posterior sagittal anorectoplasty. Look, this isn't just simply closing a hole, it's a major complex reconstruction. We literally have to identify and divide the fistula, carefully mobilize the rectum, place it exactly within the sphincter complex, and then completely reconstruct that anal canal from scratch.
Moving right along to Section 2, Persistent Cloaca Anomalies. Let's break down the anatomy of a common channel.
Okay, I want you to burn this equation right into your memory. If you have a female newborn with an anorectal malformation, plus a single common channel, plus hydrocolpus, which is just fluid accumulation in the vagina, you are definitely dealing with a persistent cloaca. In these girls, the rectum, the vagina, and the urinary tract all fail to separate during development. Instead, they abnormally join into one single channel.
So how do we manage this delicate situation? Well, because everything is joined together, that fluid accumulation, that hydrocolpus, can actually press against the urinary tract and cause severe obstruction. So step 1 involves immediate decompression and draining that fluid. In certain cases, we might even need to place a colostomy. But ultimately, this is going to require a very definitive, highly complex pelvic reconstruction down the line.
Next up is Section 3, Rectal Prolapse in Children. We need to focus on identifying the underlying cause.
Before we do anything else, we have to make a really critical diagnostic distinction. Like, how do we know for sure it's a true rectal prolapse and not just prolapsed hemorrhoids? The secret is literally in the folds. A true rectal prolapse features concentric mucosal folds. Think of them like the rings on a dartboard or target. Prolapsed hemorrhoids, on the other hand, well, they feature radial folds that point outward from the center.
Let's treat this next bit like an escape room puzzle. Rectal prolapse in kids is almost always secondary to something else. Sure, we start by looking for simple stuff: chronic constipation, diarrhea, maybe parasitic infection, or malnutrition. But if a child has recurrent or completely unexplained rectal prolapse, what serious underlying condition absolutely must you look for? The answer is cystic fibrosis. Finding that root cause is your #1 priority because usually we treat the prolapse conservatively first simply by fixing that underlying problem.
All right, Section 4, Cleft Lip and Palate. We're looking at embryology, management, and sequences.
When we're managing this condition, timing is absolutely everything. Initially, the focus isn't even on surgery. It's all about feeding support using special bottles and getting multidisciplinary care in place. Then, right around 3 months of age, we do the cleft lip surgical repair. The cleft palate repair, though, that happens a bit later, usually during the first year of life. And here is a huge exam trap. That palate must be repaired prior to significant speech development. Why? Because an open palate causes major issues with feeding, nasal regurgitation, speech, and even recurrent ear infections and hearing impairment.
And while we're on the topic of facial fusions, we have to talk about Pierre-Robin sequence, which is strongly associated with a cleft palate. Let's ditch the medical jargon and translate this into a simple chain of events. It starts with micrognathia, which just means a very small jaw. Because the jaw is so small, it physically pushes the tongue backward, a condition called glossoptosis. And that backward tongue, it physically blocks the upper airway. I really want you to remember that it's a sequence of events causing a domino effect, not just one isolated malformation.
On to Section 5, Pediatric Abdominal Trauma. Let's talk about managing solid organ injuries.
Okay, so when a child suffers blunt force trauma to the abdomen, which solid organs are most at risk? Well, coming in at number 1 is the spleen. That's the most frequently injured. That's followed by the liver, and then finally the kidney. When that injured child arrives in the ER, we follow the foundational ATLS, or Advanced Trauma Life Support Principles. Airway, breathing, circulation, disability, and exposure. We assess them systematically, step by step. If we suspect a significant internal injury in a child who is otherwise stable, the key imaging tool is a contrast-enhanced CT scan. We might also use a fast ultrasound to quickly look for any free fluid.
Now let's hammer this crucial exam trap home. If the child's vitals are hemodynamically stable, even if their CT scan shows a pretty significantly injured spleen or liver, our approach is non-operative management. We observe, we monitor their hemoglobin, we do serial exams. We absolutely do not rush them to surgery based purely on a scary-looking scan if their blood pressure and heart rate are holding steady. Oh, and remember, a negative fast ultrasound does not mean there are no injuries. It just means there isn't an obvious pool of free fluid at that exact second.
Finally, Section 6, the Rapid Revision Master Table. Let's pull together the ultimate summary.
Let's lock all of this in so you don't miss a single point. For anorectal malformations, your classic clue is the absent anus. The key is to assess the whole spine and sacrum, and the management is the PSARP reconstruction. For persistent cloaca, look for a female with a single common channel. All those systems converge, requiring highly complex reconstruction. For rectal prolapse, look for protruding concentric tissue. Your main job? Find the underlying cause, like cystic fibrosis, and manage it conservatively first. Cleft lip and palate are fusion defects where feeding and speech take priority before a multidisciplinary repair. And finally, for pediatric abdominal trauma, if you have a stable child with a solid organ injury, we almost always default to non-operative management. And that brings us to the end of our...
Let's start right at the top of the plumbing system with Section 1, UPJ obstruction.
Imagine the kidney as a basin that collects fluid, and the ureter is the main drain pipe leading out of it. A UPJ obstruction is a blockage exactly at the junction where that basin meets the draining tube. Because the fluid can't drain properly, it obviously backs up, and this makes it the single most common cause of pediatric hydronephrosis, which is just the medical term for a swollen, waterlogged kidney. In kids, you'll often see this present as flank pain, recurrent urinary tract infections, or even blood in the urine.
Now here's a massive pro tip for your clinical exams. Pay close attention to this comparison. If you're looking at an ultrasound and you see a swollen kidney with dilated calyces, but a totally normal, non-dilated ureter right below it, boom, you are looking at a UPJ obstruction. The blockage is at the top, so the tube below it is empty and normal size. Contrast that with a distal obstruction further down the line, where both the kidney and the ureter would be visibly swollen.
So how do we actually fix this upper blockage? Well, first, doctors need to know exactly how bad the backup really is. To do that, they use a specialized functional scan called a MAG3 diuretic renogram. It's a brilliant test that checks both fluid drainage and the differential function of the kidneys. If the drainage is severely obstructed or if kidney function is dropping, we move to the definitive surgical fix, a pyeloplasty. This is where surgeons physically reconstruct that blocked junction to get everything flowing normally again.
Moving down the pipes, we hit Section 2, Vesicoureteric reflux.
In any normal plumbing system, fluid should really only flow in one direction, right? Down. Vesicoureteric reflux, or VUR, is the retrograde or backward flow of urine from the bladder back up into the ureter and sometimes all the way back into the kidney itself. This retrograde flow is a huge problem. Why? Because it brings bacteria from the bladder straight up into the kidneys. That leads to recurrent febrile infections, dangerous kidney scarring, hypertension, and ultimately it can cause chronic kidney disease.
Check out this table showing the international grading system for VUR. It illustrates exactly how the backward leak gets progressively worse. Grade 1 is just a little reflux into the ureter. Grade 2 reaches the renal pelvis, but without any swelling. By grade 3, we start seeing mild to moderate dilatation and blunting. Grade 4, now we have moderate dilatation and twisting, also called tortuosity.
And grade 5 is the worst-case scenario: gross dilatation, severe twisting, and major changes to the kidneys. We diagnose and grade this using an MCUG or VCUG scan, which literally lets us watch the urine flowing backward. Higher grades mean a higher risk of permanent damage, and they often require serious interventions like ureteric reimplantation.
Continuing our top-down journey, Section 3 takes us to posterior urethral valves.
Imagine a physical flap of tissue literally blocking the main exit pipe from the bladder. That's what posterior urethral valves, or PUV, are: abnormal congenital membranous folds in the posterior urethra. This is the absolute most common cause of bladder outlet obstruction in male infants. Because the urine is totally blocked from leaving the body, the bladder has to work overtime, becoming thick-walled and strained. In severe cases that happen before birth, the baby can't excrete urine into the womb. That leads to dangerously low amniotic fluid, which can cause terrible respiratory distress at birth because the lungs just haven't developed properly.
Let's look at how PUV actually presents over time. First, antenatally, weeks before birth. An ultrasound will likely show bilateral hydronephrosis. Both kidneys are swollen because the backup starts all the way down at the urethra. Second, at day 0, right at birth. The classic clue is a male infant with a very poor urinary stream. Finally, in the weeks following birth, an MCUG or VCUG is performed, classically revealing a dilated posterior urethra and a heavily trabeculated, thick-walled bladder.
Now, treating PUV has to be highly systematic. You can't just rush straight into surgery. Step 1, you have to immediately stabilize the child and relieve the pressure by draining that bladder with a catheter. Step 2, because those kidneys have been backed up for so long, you must correct any dangerous fluid and electrolyte abnormalities and treat any infections. Only then do we finally reach step 3, the definitive surgical fix, which is an endoscopic valve ablation to destroy those folds and open up the pipe.
There are 2 vital facts you need to remember here for your exams and clinical practice. Fact 1, PUV occurs almost entirely exclusively in boys. Fact 2, tragically, you can't just fix the plumbing and assume everything's perfect. Long-term kidney dysfunction and bladder issues can't persist long after those valves are successfully destroyed. These patients are going to need lifelong monitoring.
All right, let's exit the internal plumbing and look at external anatomy with Section 4, hypospadias.
So, in a normal anatomical setup, the urethral opening is right at the tip of the penis. Hypospadias is a condition where that opening, the meatus, is abnormally located somewhere on the ventral or underside surface of the penis. It could be anywhere from just below the tip all the way down to the scrotum. This usually comes with 2 other physical signs: a hooded foreskin and an abnormal downward curvature of the penis during an erection, which is medically known as chordee.
Don't fall for this classic exam trap. Hypospadias means a ventral opening on the underside. Epispadias, which sounds super similar, is the exact opposite. It means a dorsal opening on the top side. Just remember the difference between ventral and dorsal, and you'll nail this diagnosis every time.
And that brings us to an absolutely critical warning. If you see an infant with hypospadias, do not circumcise them before a proper surgical evaluation. Why? Because to straighten the penis and reconstruct the urethra so the opening is at the tip, pediatric surgeons desperately need that extra preputial tissue from the foreskin. If it gets removed prematurely through a standard circumcision, you've basically just thrown away the spare parts needed to fix the plumbing.
Finally, our blueprint concludes with Section 5, cryptorchidism, which is more commonly known as undescended testes. During fetal development, the testes are supposed to travel all the way from inside the abdomen down into the scrotum. Cryptorchidism is what happens when one or both of them failed to make that full journey. This is a big deal. If the testis isn't in the scrotum where it belongs, it gets way too warm. That drastically increases the risk of lifelong infertility. On top of that, it significantly increases the risk of testicular malignancy and leaves the testicle highly vulnerable to torsion.
If the testis isn't in the scrotum, it's usually just hiding somewhere along its normal descent path. Look at this breakdown. The vast majority, about 70%, get stuck right in the inguinal canal. Another 20% are found higher up in the abdominal cavity, and roughly 10% are in the prepubic region. Because a massive 70% get stuck in the inguinal canal, it perfectly explains why inguinal hernias are incredibly common in these patients. That pathway just never closed up properly.
Now here's a vital clinical distinction you have to make during an exam. A retractile testis has pulled up due to a hyperactive muscle reflex, but you can gently pull it down into the scrotum and it'll stay there temporarily. That is fundamentally different from a true undescended testis, which simply cannot be maintained normally in the scrotum at all. A true undescended testis requires a surgical relocation called an orchidopexy to preserve fertility and allow for proper cancer screening down the road. Okay, before we wrap this up, let's do a quick pop quiz to see if you're tracking with me. Imagine a young child presents to your clinic with recurrent fever-inducing UTIs. Based on the plumbing issues we just covered, what should your immediate clinical suspicion be? Think back to the backwards flow we discussed earlier. If you guessed vesicoureteric reflux, or VUR, you nailed it. Now take a screenshot of this table because it is an absolute goldmine for studying. Let's rapidly review. For PUV, look for a male infant with a porous stream, diagnosed with an MCUG, and treated with a valve ablation. For VUR, watch for recurrent febrile UTIs, also diagnosed with an MCUG, treated with observation or surgery. For UPJ obstruction, expect hydronephrosis but a normal ureter, diagnosed via diuretic renogram, and treated with a pyeloplasty. And for our external diagnoses, hypospadias presents with a ventral opening requiring surgical repair, and cryptorchidism presents with an absent testis requiring an orchidopexy.
As you commit 1, hernias and hydrocele.
Okay, let's radically simplify the core pathology here. Basically, everything in this section starts with the processus vaginalis. Think of this like a tiny tunnel, a persistent abdominal pocket that really should have sealed shut before the baby was even born. But when it stays open, well, it creates this abnormal pathway that lets fluid, or even abdominal contents, travel down where they absolutely shouldn't be.
So we're looking at two main types of fluid collections here. On one side, you've got a communicating hydrocele. Since that pocket is wide open, the fluid just sloshes back and forth, fluctuating over time, and that might actually need surgical repair. But on the other side, the non-communicating hydrocele, the door is shut tight, trapping an isolated collection of fluid. And because it's closed off, the baby's body will usually just naturally absorb that fluid over time.
Now, what if that open pocket catches a loop of bowel instead of just fluid? That is when you get a pediatric inguinal hernia, which is usually the indirect kind. The massive red flag you're looking for is a swelling in the groin that visibly bulges when a child cries or strains. And here's a pro tip. Unlike a simple fluid hydrocele, if you shine a light on this swelling, it won't glow. If that bowel gets trapped or incarcerated, it's basically like a severely kinked garden hose. It can quickly lead to strangulation, where the tissue loses blood flow, leading to bowel ischemia. And yeah, that requires urgent surgery.
Section 2. Testicular torsion. We're moving into red alert territory now. This timeline shows you just how incredibly fast things go south. At minute 1, you literally have a physical twisting of the spermatic cord. Within 10 to 30 minutes, this twist blocks the veins, so blood can't get out. Give it 1 to 3 hours, and the arteries are compromised, meaning fresh oxygenated blood can no longer get in. If you don't intervene, by hours 4 to 6, it reaches complete ischemia. We're talking irreversible tissue death. The clock is quite literally ticking.
Because of that ticking clock, spotting these classic signs instantly is absolutely crucial. A patient is going to have sudden, severe, one-sided pain, very often with nausea and vomiting. Physically, you'll see a high-riding testes that sits horizontally. But listen, the biggest clinical clue here is an absent cremasteric reflex. That means the muscle that normally pulls the testes upward just isn't responding at all.
So here's a huge clinical dilemma, a classic exam trap actually. If a kid comes in with these classic signs, do you delay surgery to grab an ultrasound and confirm the lack of blood flow? The answer is absolutely not. No way. You jump straight into these 4 surgical steps. Step 1, urgent exploration. Do not delay for imaging. Step 2 is physically untwisting the affected side. Step 3 is vital. You perform a bilateral orchidopexy, meaning you surgically secure both testicles. Why both? Because the anatomical flaw that caused the twist in the first place is usually present on both sides. And finally, step 4, if the tissue has already died, well, it has to be removed.
Section 3. Bladder exstrophy and epispadias.
Transitioning away from sudden emergencies, we're now dealing with incredibly complex anatomical puzzles. Basically, bladder exstrophy is a failure of the lower abdominal wall and the front of the bladder to fully form before birth. The result? The delicate inner lining of the bladder is completely exposed to the outside air. The infant can't store urine, and structurally they have pubic symphysis diastasis, which just means their front pelvic bones are widely separated rather than joined together. It really helps to visually contrast these two related conditions to keep them straight. Hypospadias is when the urethral opening sits on the ventral or underside of the penis. But epispadias, which is heavily linked to the exstrophy spectrum we were just talking about, is when that opening sits on the dorsal or top surface.
Because this whole complex is so profound, the management has to be meticulously mapped out on a multi-stage timeline, stretching from infancy right into childhood.
Stage 1, right in the newborn phase, is all about just closing the bladder and abdominal wall. Stage 2 waits until the toddler years to reconstruct the urethra and external genitalia. And then finally, Stage 3 happens in childhood, focusing on continence procedures to help the child actually hold and control their urine.
Section 4. Ambiguous genitalia and disorders of sex development.
Take a look at this diagnostic panel. When a newborn presents with atypical genitalia, medical teams never, ever rush irreversible surgical or gender assignment decisions. Instead, they immediately kick off this multidisciplinary emergency evaluation. They run metabolic blood tests to check electrolytes, glucose, cortisol, and specific hormones like 17-hydroxyprogesterone. At the exact same time, they're running genetic tests, like a karyotype, to map out the baby's actual chromosomes alongside a full hormonal profile and a pelvic ultrasound to see what internal structures are present.
So why rush those blood tests? Because we are aggressively hunting for salt-wasting congenital adrenal hyperplasia, or CAH. This is a condition that causes virilization, male physical characteristics, in infants with XX chromosomes. But the real danger here is metabolic. It acts literally like a bomb going off in the body, causing dangerously low sodium, low blood sugar, low blood pressure, and dangerously high potassium. If you see an infant with atypical genitalia paired with vomiting, dehydration, and high potassium, it is CAH until proven otherwise. You absolutely must stabilize those life-threatening metabolic drops before doing anything else.
Section 5. Neurogenic bladder. A breakdown in the nervous system, like what you'd see in a kid with spina bifida, creates two totally distinct structural problems. On the left, we have a high-pressure bladder. The muscle is overactive and incredibly stiff. The massive hidden danger here is that this high pressure can silently back up and completely destroy the upper urinary tract and the kidneys. On the right, you've got a low-pressure bladder. This is a floppy, areflexic bladder, meaning it lacks normal reflexes. It doesn't empty well at all, which leads to massive urinary retention and just continuous overflow leakage. That silent threat of permanent kidney damage we just talked about, that literally dictates every single management step we take. Step 1 is the absolute ultimate priority, protecting renal function at all costs, with regular ultrasounds. Step 2 is using medications to get those bladder pressures down to a safe level. Step 3 is making sure the bladder actually empties properly, usually by using clean intermittent catheterization, or CIC, where a small tube is passed to drain the urine. And then Step 4 focuses on improving the child's daily continence.
Section 6. Rapid revision. All right, let's lock it all in. This rapid revision matrix brings everything we've talked about together into one simple table. For hernias and hydroceles, your primary clue is groin swelling caused by that persistent pocket, managed by surgical repair. For torsion, sudden pain and an absent reflex point to a true, red alert emergency demanding immediate exploration. Bladder extrophy presents with exposed mucosa requiring complex multi-stage reconstruction. Atypical genitalia demands that doctors urgently exclude CAH by stabilizing the patient's metabolism first. And finally, a neurogenic bladder requires you to prioritize and protect the kidneys above all else.
I'm going to leave you with this
All right,
final...
Section 1. We're starting our journey with our youngest patients, looking closely at newborn hips and feet. Let's dive into developmental dysplasia of the hip, or DDH. What we're looking at here is an acetabulum, the hip socket, that just hasn't developed properly, and that leads to instability of the femoral head. Now, what's really interesting is that a lot of the risk factors actually come down to what we call packaging issues. Think about it: female sex, breech presentation in the womb, being a firstborn, family history, and oligohydramnios, which in simple terms just means low amniotic fluid. In a lot of these scenarios, there literally just isn't enough room in the womb for the hips to develop in a nice, relaxed, normal position.
Now, DDH isn't just one single problem, it's an entire spectrum of severity. Down on the mild end, you've got simple hip instability. Step it up a notch and you hit subluxation, which means the joint is partially out of the socket. And then at the absolute peak, you have a complete dislocation. A huge takeaway here: if you're examining an older infant and you notice limited hip abduction, meaning you can't easily open their legs out to the side, that is a massive warning sign that you might be dealing with a dislocated hip.
Okay, here is a classic exam trap, so pay attention. You have to remember the difference between these two famous clinical tests. The Barlow test is provocative. It actively attempts to dislocate an unstable hip by pushing back. On the flip side, the Ortolani test is therapeutic. It attempts to reduce or pop back into place a hip that is already dislocated. A simple way to remember it: Barlow dislocates, Ortolani reduces. If you have an infant with an unstable hip and a positive Ortolani sign, you're looking squarely at a DDH diagnosis.
It's fascinating how our approach to diagnosing and treating DDH shifts completely as a baby grows. In early infancy, before the baby's bones have actually hardened, cartilage is totally invisible on an X-ray. So we rely 100% on ultrasound to see the hip. And our first-line treatment is the Pavlik harness to gently hold things in place. But as time passes and the child gets older, that femoral head ossifies. It turns into actual bone. At that point, ultrasound is useless and we switch over to X-rays. For those older kids, or in cases where the harness just didn't work, we have to escalate to closed reduction, open reduction surgery, or even an osteotomy, which means surgically cutting and reshaping the bone itself.
Staying in the infancy stage, let's talk about clubfoot, formerly known as congenital talipes equinovarus or CTEV. This presents as a really rigid deformity defined by the CAV acronym. Cavus means a high arch. Adductus means the front of the foot turns inward. Varus means the heel turns in, and equitus means the foot points straight down, kind of like a horse's hoof. What's absolutely vital to note here is that the calf muscle on the affected side is actually smaller. And while it's often an isolated issue, this rigid deformity is frequently linked to complex neuromuscular disorders like spina bifida and arthrogryposis.
So, how do we fix this CTEV deformity? The standard initial treatment is the Ponseti method, and it follows 4 very specific stages. First, serial manipulation to gently stretch the foot. Second, serial casting to hold those tiny microcorrections in place. Third, an Achilles tenotomy, which is a minor procedure to release the tight heel cord to fix that equinus pointing down issue. And finally, a foot abduction brace. Now, the crucial clinical insight lies right there in step 4. Even if the first 3 steps are flawlessly executed, poor bracing compliance from the parents practically guarantees a huge risk of the clubfoot coming right back. As our patient grows out of infancy and into childhood, typically around 4 to 8 years old, we leave DDH behind and face section 2, a completely new hip challenge.
Let's dive into Legg-Calvé-Perthes disease. In the simplest terms, this is avascular necrosis of the developing femoral head. Avascular necrosis means the bone literally loses its blood supply and, well, starts to die. We mostly see this in young boys between 4 and 8 years old. They'll typically walk into your clinic with a limp, and upon examination, you'll find they have limited hip abduction and internal rotation. Interestingly, they might complain of hip pain, but very often they'll actually complain of referred knee pain. The golden rule here: never ever ignore a limping child with a sore knee, always check the hip. On an X-ray, the bone goes through a pretty miserable life cycle. First it flattens, then sclerosis or hardening occurs, then fragmentation, where it literally breaks apart, and finally reossification, where it heals. Because the bone gets incredibly soft during this whole ordeal, our ultimate treatment goal is containment. We want to keep that soft femoral head perfectly nestled inside the hip socket, so the socket acts like a mold. This ensures the bone heals nice and round, rather than flat. We achieve this through observation, changing their activities, physio, bracing, or even surgery. And keep this rule of thumb in mind. The younger the child is when this happens, the better their natural capacity to remodel the bone, which means a far better prognosis. Moving right along into the teenage years, we hit section 3. The rapid adolescent growth spurt introduces a massive mechanical strain on the body, introducing the risk of the hip actually slipping out of place.
Picture an ice cream scoop slipping right off its cone. That is exactly what happens in a slipped capital femoral epiphysis, or SCFE. The femoral head, the epiphysis, literally slips relative to the neck of the bone, right through that vulnerable growth plate. This almost exclusively happens to adolescents. The classic presentation? Usually an overweight or obese teenager, sometimes with underlying endocrine disorders. They walk in with a limp, groin pain, or once again that incredibly tricky referred knee pain. But here's your major physical clue. Their leg is stuck pointing outward in external rotation because they've suffered a complete loss of internal rotation. Because of this extreme vulnerability, there are some massive exam traps and clinical warnings you need to know. First off, if you suspect the slip is unstable, you absolutely must avoid ordering a frog leg lateral X-ray. The positioning alone can make the slip completely detach. Second, never, ever forcefully reduce an unstable SCFE. Do not try to pop it back into place. You must surgically fix it in situ, exactly where it lies. If you try to manipulate it, you severely increase the risk of 2 major complications: the bone dying from avascular necrosis or a severe loss of joint cartilage known as chondrolysis. So, we've looked at specific, isolated issues by age. Now let's shift gears for section 4, looking at a condition that spans an entire lifetime and requires constant vigilance: cerebral palsy.
A massive trap to avoid here is assuming that everything about cerebral palsy is static. It's not. The initial injury to the developing brain is non-progressive. The brain damage itself doesn't get worse over time. However, the resulting orthopedic manifestations, the musculoskeletal issues like severe spasticity, curving of the spine and scoliosis, and fixed joint contractures, those absolutely progress and worsen as the child grows up. Because these kids deal with immense muscle spasticity, they're at an incredibly high, ongoing risk of their hips being slowly pulled right out of the socket, leading to hip subluxation and eventually dislocation. And the more severe their motor impairment, the higher that risk gets. That's exactly why early and continuous hip surveillance is absolutely essential. Managing this isn't a one-doctor job. It's a massive multidisciplinary team effort. We're talking physio and occupational therapy to maintain motion, orthoses for support, botulinum toxin injections to temporarily paralyze spastic muscles, and eventually orthopedic surgery to release fixed deformities. It's a constant ongoing battle against the progression of the physical symptoms.
Okay, we've covered a lot of ground. Let's move to Section 5 and pull all of these chronological stages, the complex acronyms, and the intricate anatomical details together into one definitive rapid review. Let's lock this in to really cement your understanding by connecting the condition to the main clue and the treatment. First up, DDH. Watch for the unstable infant hip where Barlow dislocates and Ortolani reduces, treated with a Pavlik harness. Next, clubfoot, or CTEV. Remember, the rigid cavo deformity cured by the Ponseti method of serial casting. Third, Perthes. That is your 4 to 8-year-old boy with a limp from AVN, where we focus on containment to remodel the bone. Fourth, SCFE. The obese adolescent with referred knee pain and a loss of internal rotation. Fix it exactly where it lies to avoid chondrolysis. And finally, cerebral palsy. A static brain injury causing progressive musculoskeletal deformity, demanding early and continuous hip surveillance. As we wrap up this explainer,
Supracondylar elbow fractures. This is the most common child elbow fracture you're going to see.
Picture this. A child comes in right after a playground accident. This fracture should instantly jump to the front of your mind. Let's walk through exactly how this unfolds on a timeline. At 0 seconds, you have the classic mechanism, a fall on an outstretched hand. You know, the classic Fuchs injury. A split second later, all that force travels up the arm, causing a severe hyperextension injury right at the elbow. Now, fast forward about 4 hours. If this is a severe, displaced fracture, that kid is at a massive risk for ischemia. The blood supply gets dangerously cut off, which can trigger compartment syndrome and lead to a devastating Volkmann's ischemic contracture. And if it isn't fixed properly, 6 months down the line, they could develop a cubitus varus deformity, where the arm is permanently angled inward.
Now, what's really interesting about this detailed breakdown is how the Gartland classification directly dictates our management. The table makes it incredibly simple. Type 1 is undisplaced. Simple cast immobilization works great here. Type 2 is displaced, but the posterior cortex is still intact, meaning the back wall of the bone is holding together, so we can use selective casting or operative fixation. But once we hit Type 3, that's completely displaced. You need closed reduction and percutaneous pinning. And Type 4, that is multidirectionally unstable and absolutely requires surgery. The degree of displacement literally draws the map for how we treat it.
So let's lock in these exam traps and real-world red flags. You absolutely have to assess the pulse and neurostatus every single time. Why? Because the brachial artery and the median or anterior interosseous nerves are right in the danger zone. A pulseless hand is a strict drop-everything emergency. Miss it and that cut-off blood supply causes the Volkmann contracture we just talked about. Also, keep in mind that cubitus varus isn't something you'll see on day 1. It's your classic late-stage deformity.
Moving right along to Section 2, Salter-Harris growth plate injuries. It's all about protecting the physis.
So we're moving from the bone shaft down to the growth plate, where any damage carries the huge risk of permanent growth arrest. The Salter mnemonic makes the step-by-step breakdown instantly memorable. S is for straight across the physis, that's type I. A is for above, meaning the fracture goes through the physis and exits above into the metaphysis, type 2. L means lower, exiting below through the epiphysis, type 3. T stands for through everything, metaphysis, physis, and epiphysis, that's type 4. And finally, ER means everything ruined or crushed, that's your type V crush injury.
Check out the visual weight of that type 2 slice in the data. It makes up a massive 70% of these fractures. The above to metaphysis fracture is by far the most common one you'll encounter. It's a super common trap to assume the most severe types are the most frequent, but type 2 is the one you'll see over and over. That said, types 3 and 4 are major bad news because they hit the articular surface of the joint, and type 5, that is particularly dangerous because a pure crush injury can easily be missed entirely on that very first X-ray.
All right, Section 3, Bone and Joint Infections. Make no mistake, these are orthopedic emergencies.
If you have a feverish kid who is flat out refusing to walk or move their arm, you are dealing with a genuine emergency. Let's do a clear side-by-side comparison of two really tricky conditions. With septic arthritis, the focus is the joint itself. You've got a febrile child with a hot, swollen, acutely painful joint. The definitive diagnostic move? Urgent joint aspiration, followed by drainage and IV antibiotics. On the flip side, with acute hematogenous osteomyelitis, the focus is on the metaphysis of the long bones. You still have a fever, but the pain is localized right to the bone. The major trap here? Early X-rays for osteomyelitis usually look completely normal. You need to get an MRI early on because it's highly sensitive.
But here is the crucial takeaway. Whether you're dealing with a joint infection in septic arthritis or a bone infection in osteomyelitis, Staphylococcus aureus is the most common organism in both. That single shared enemy bridges these two totally distinct clinical pathways. Now for Section 4, Rickets and Osteogenesis Imperfecta. Let's look at underlying bone weaknesses.
So why do some children have underlying weaknesses that leave them so vulnerable to these deformities and fractures in the first place? We need to clearly distinguish these two pathologies. Rickets is basically a problem of defective mineralization in growing bones, most often caused by a vitamin D deficiency. Osteogenesis imperfecta, or OI, is a whole different ballgame. It's a core genetic pathology resulting in defective type 1 collagen. So one is a vitamin and mineral issue. The other is a structural genetic blueprint issue.
This table brilliantly anchors the visual clues you'll actually see in a clinical exam. For rickets, you're looking for bowed legs, frontal bossing, which is a prominent protruding forehead, and a rachitic rosary, which literally feels like widened beads along the rib joints. For osteogenesis imperfecta, the clues are totally different. You'll see recurrent bone fragility and fractures, an undeniable blue tint to the white part of the eyes, dentinogenesis imperfecta, meaning discolored, unusually weak teeth, and sometimes even hearing loss.
Finally, Section 5, Burns, Trauma, and Abuse. Let's talk overarching protocols and safeguarding.
We are shifting gears here and taking a much more serious tone because we're discussing the protocols that literally save children's lives. Whether we're looking at major trauma or severe burns, our initial management always falls back on those core ATLS principles: A, B, C, D, E. Airway protection with cervical spine care, breathing, circulation, disability, and full exposure. But here's the pediatric nuance you can't miss. Children have much thinner skin, so their risk of hypothermia is massive. That's why exposure has to be managed so carefully. Also for burns, fluid resuscitation is critical. But listen to this. The fluid calculation is based on the percentage of total body surface area burned, not just the physical size of the wound itself.
And we have to talk about safeguarding. These are the stark, undeniable red flags of non-accidental injury or child abuse. You have to be incredibly vigilant for a history that just doesn't match the child's developmental abilities or is constantly changing. Watch out for unexplained delays in seeking care, multiple injuries of varying ages, or patterned bruises in unusual spots. Radiologically, posterior rib fractures, often from a child being squeezed, and metaphaseal corner or bucket handle fractures, which happen from forceful pulling and twisting, are highly suspicious for inflicted injury.
Which brings us to the absolute golden rule of safeguarding. The child's safety comes first. Above everything, if an infant presents with an inconsistent history or any of those specific fractures we just covered, you never, ever dismiss it. Suspected non-accidental injury mandates a rigorous safeguarding assessment, multidisciplinary evaluation, and incredibly meticulous documentation.
All right, let's tie this whole thing together with a rapid revision table to make absolutely sure no points were missed today. Supracondylar fractures, linked to Foch with major artery and nerve risks. Salter-Harris type 2 is your most common physeal break. Septic arthritis needs urgent joint aspiration, while osteomyelitis demands an early MRI. Rickets is a mineralization defect, whereas OI is a collagen defect. And finally, pediatric trauma and burns require ABCDE with an unwavering
Let's start
commitment.
at the very top of the head with Section 1, craniosynostosis. You know a baby's skull isn't just one solid bone, right? It's basically a giant puzzle made of plates connected by flexible seams called sutures.
And this is by design. It allows the brain to grow rapidly in those first years of life. But craniosynostosis is the premature fusion of one or more of those sutures. When they fuse too early, the skull grows into a totally abnormal shape, causing facial asymmetry. But more dangerously, it restricts brain growth and leads to raised intracranial pressure. And hey, here's a massive exam trap to commit to memory right now. If you see a clinical scenario describing premature suture fusion, your immediate diagnostic instinct must be craniosynostosis. While mild cases just get specialist surveillance, severe cases require cranial vault surgery, which is essentially cranial remodeling. The goals of this surgery brilliantly illustrate what we're trying to achieve. It hits 4 intertwined, absolutely vital targets. First, relieve that dangerous intracranial pressure. Second, give the brain the physical space it actually needs to grow. Third, correct the skull deformity for structural and cosmetic normalization. And fourth, protect the child's vision, because honestly, vision can be permanently damaged if that pressure is left unchecked. Moving smoothly down our anatomical map, we hit section 2, congenital neck masses. Location is literally everything here when differentiating these two commonly confused lumps. First up, the thyroglossal duct cyst. The key identifier, it's a midline neck swelling, right in the center. Because of its anatomical attachment, it actually physically moves upwards when the child swallows or sticks out their tongue. In stark contrast, we have the branchial cyst. This presents as a painless lateral neck swelling, sitting off to the side, right along the border of the sternocleidomastoid muscle. So remember, midline means thyroglossal, lateral means branchial. Now, if there's one surgical intervention you need to remember for the neck, it's this classic exam trap. You might be thinking, oh, it's a cyst, just cut the cyst out. Wrong. A simple excision has a notoriously high recurrence rate. The definitive treatment for a thyroglossal duct cyst is always the cystrung procedure. This meticulous surgery removes not just the cyst, but the entire thyroglossal tract and the central portion of the hyoid bone, ensuring it never comes back. Before we leave the neck, we absolutely have to mention cystic hygromas, which are lymphatic malformations. These present as soft, compressible swellings, often in the posterior triangle of the neck. A really cool clinical sign is that they mate, but don't let that soft description fool you. Large lesions are absolute airway emergencies because they can compress the windpipe. If the airway is safe, the definitive first-line treatment isn't always surgery. It's often sclerotherapy. That's where we inject sclerosing agents like doxycycline or bleomycin to shrink the mass right from the inside. Let's move to section 3 and see how this builds as we descend into the chest for congenital pulmonary malformations. We're going to group 2 major respiratory conditions together because they behave very similarly in an emergency: CPEM and congenital lobar emphysema. Both of these anomalies present with severe neonatal respiratory distress. The baby is struggling to breathe. Because of that, the initial management is identical: give oxygen, provide respiratory support, and stabilize the infant. If the disease is severely symptomatic, both share a definitive surgical solution, a lobectomy, which simply means removing the diseased lobe of the lung. The only real caveat here is for asymptomatic CPEMs, where treatment is individualized based on the lesion's size and its rare potential to turn malignant later on. Then we have this completely fascinating anomaly: pulmonary sequestration. By definition, this is a piece of lung tissue that does absolutely nothing. It's totally non-functioning. But the wildest part is its blood supply. Instead of getting deoxygenated blood from the pulmonary circulation like a normal lung, it steals blood directly from the systemic circulation via an aberrant or rogue systemic artery. To fix this, surgeons have to perform CT angiography to perfectly map out that rogue artery before they can safely go in, ligate it, and resect the useless tissue. I really want to make sure this sticks because it's a huge exam trap. If you ever see a case involving lung tissue with a systemic arterial supply, your brain must immediately snap to pulmonary sequestration. That unique blood supply is its defining signature. No exceptions. Shifting our focus now to section 4, vascular and lymphatic malformations on a systemic level. The most common one you'll see here is the infantile hemangioma, often called a strawberry mark. What's unique is its natural timeline. It goes through 3 distinct phases. First, the proliferative phase where it rapidly grows. Second, a plateau phase where it just stops. And third, a phase of gradual involution, where it slowly shrinks and disappears on its own over a few years. Because of this timeline, uncomplicated lesions just need simple observation. But if it's growing over an eye, blocking an airway, or threatening cardiac failure, we have to step in. The first-line medical treatment for a problematic hemangioma is oral propranolol.
Let's rapidly compare the other three main vascular anomalies. It's all about matching the clinical signs to the treatment. Venous malformations are soft, bluish, and they actually enlarge when the child strains, like when crying or pushing during a Valsalva maneuver. The treatment? Sclerotherapy. Lymphatic malformations, which we touched on, are observed if small or treated with sclerotherapy. But arteriovenous malformations, or AVMs, are different beasts entirely. These are high-flow lesions. They're warm to the touch, you can feel a pulsation, and hear a rushing bruit. Because of the high blood pressure inside them, you can't just inject them. They require specialist vascular imaging and endovascular embolization to block off those abnormal vessels. Okay, this brings us to a heavy piece of medical jargon you absolutely must decipher: the Kazabok-Murat phenomenon. What is it? Well, it's a dangerous trio of blood issues. Thrombocytopenia, meaning low platelets, consumptive coagulopathy, where your body is using up all its clotting factors, and anemia. The exam trap: if you see this specific, terrifying trio of bleeding disorders associated with a giant vascular tumor, it equals Kazabok-Murat phenomenon. The tumor is essentially trapping and destroying the child's platelets and clotting factors, and it requires incredibly urgent specialist care. So the crucial point is, surgical emergencies don't just happen in the chest or the head. Section 5, Pediatric urolithiasis. While a small, non-obstructing kidney stone just gets hydration and painkillers, an obstructed, infected urinary system is a massive, life-threatening urological emergency. If infected urine is trapped behind a stone, that child can quickly go into sepsis. Here is the step-by-step life-saving protocol. Step 1, administer IV antibiotics immediately. Step 2, urgent decompression. You have to relieve the pressure and drain the pus, either by inserting a small stent tube from below or placing a nephrostomy drainage tube directly into the kidney through the back. Step 3, definitive stone treatment, like using shock waves to break it or going in for surgery, happens much, much later. I really cannot emphasize this enough. This is perhaps the most critical exam trap and real-life clinical rule in urology. With an infected, obstructed urinary system, you must drain first and leave the definitive stone treatment for later. If you try to blast or remove that stone while the kidney is under high pressure and full of infected pus, you will literally push that infection directly into the bloodstream. Drain the infection, let the patient recover, and deal with the rock later. We have covered a tremendous amount of ground today. Let's bring it all together for Section 6, the complete management summary. I absolutely love this master summary table because it completely explains the unifying philosophy of pediatric surgery. When you compare the initial treatment for these conditions against the definitive surgical fix, a perfect pattern emerges across the board. Across almost every single condition we've discussed today, initial stabilization always precedes the definitive surgery. Treating an infection before a cystrung procedure, securing an airway before injecting a cystic hygroma, providing respiratory support before a lobectomy, or draining an infected kidney before treating the stone. The pattern is crystal clear. You manage the acute threat to life and function first, creating a safe window for the definitive, complex anatomical repair. And that brings us to the end of our explainer. We've talked about scalpels, sclerotherapy, and stents. But when a child's anatomy develops differently, how much of our surgical success relies purely on timing? Waiting for an infantile hemangioma to plateau, rushing to decompress an infected kidney, or perfectly timing a cranial vault expansion so a growing brain has room to thrive? It's not just about knowing how to cut, it's about knowing exactly when. Thank you for joining me on this deep dive. Keep questioning, keep learning, and I'll catch you next time.